As a reminder, this podcast covers sensitive and sometimes difficult medical topics. Listener discretion is advised.
Hey everybody, and welcome to episode 3 of No Referral Required.
Hey guys.
We are so glad that you're here. We're all here. Everybody's
Mandy.
back. It's Mandy.
It's Lara. Hi.
And I'm Courtney. And we are just so glad that you have chosen to join us today. And we have a wonderful guest with us.
So
today.
excited.
We have Lara, a friend of ours who is an anesthesiologist.
Yay!
Woohoo! Drug pusher.
Yay!
We're so excited she's here for numerous reasons, but interesting to note, 75 to 80% of the American population at some point is going to have general anesthesia. And I think it's a topic that a lot of people, if they're not in the medical field, don't know a lot about. It's kind of mysterious.
A lot of job security there.
How exciting.
Yeah. So we thought we would be excited to learn a little bit more about what life is like in your field. So maybe we could start. Tell us a little bit about your background and why you chose anesthesia.
Ooh, my background. So I think going into medical school, I would say anesthesia is one of the fields that gets the least attention.
Oh.
So you barely have 5 days of a rotation when you're trying to decide what you want to do for the rest of your life. And I had my 5 days and I said, nope.
Promising start.
Not doing that. And I think it's because it's so high. It has so many high-level skills that you can't let someone, walk through the door and start doing all of the exciting stuff on day one.
Oh, yeah, sure. So
Right.
you're
Yeah, that
observing.
makes sense.
Yeah.
Right.
So you're not hands-on for a long time.
Yeah.
Right.
Yeah.
And a lot of the time, the residents that they pair you with are very new themselves. And so it's even more stressful to have a medical student with you. And so oftentimes the residents would be like, hey, do you want to have an early day? And go home.
Code
I was
for
like,
Get out of
Yeah,
here.
Get out of my
space.
space.
And so I was like, oh, man, this is pretty boring. Like, I think I'm not going to do anesthesia. And so the way my medical school worked is that we were paired with a mentor to kind of go through the end of medical school with you, applications, where you're going to, do sub-Is, things like that, just to be like a mentor with you. And you give them kind of the gist of like what you want to go into. And so I was thinking, I really like critical care. I liked pediatrics. I liked obstetrics. So I gave them all of those. And they gave me the chief of peds critical care, who was an anesthesiologist by training. And my day with her was Tuesdays, which was her OR day.
Oh, there you go.
Yep. And so we ended up in the OR, and she changed the whole trajectory of my life.
Oh, wow. Because you got to really get in there and kind of see what it's,
and I mean,
what it's really like.
She did peds, so like we were just holding these little kids and we were singing them songs and telling them stories, and it was the best. She was amazing.
Now, you are a specialist in anesthesia. And I
So
think
they say.
You are special.
I've seen it with my own eyes. I think that's something a lot of people don't know, that there are specialties within anesthesia.
Yeah, what does that mean?
And that there
Yeah.
are concentrations of
Yeah.
specific kind of skills and populations different. So it's not just, you can't just slot in one anesthesiologist, for every single thing.
Sure.
Could you tell us a little bit more about
Yeah.
what specialties exist and about your choice?
So we're all going to do a 4-year residency. Everybody does a little bit of all of the specialties. And then if you want to, you can practice as a general anesthesiologist. And depending on where you practice, you may do more or less of all of those things. Or you can choose to do a fellowship. I did my fellowship in obstetric anesthesia. You can do pediatric anesthesia. You can do critical care, where you're more in the intensive care units. You can do pain medicine. You can do palliative care. You can do regional anesthesia. So depending
Which
on
is blocks, not part of the country.
What are we saying?
Parts
Okay.
of the body.
This is Southern anesthesia. What
that
does Southern anesthesia look like?
Northern, West Coast.
Oh, man. Pacific Northwest. Okay.
Regional as in block an arm.
Oh,
Yes.
okay,
Block
okay,
the
okay.
leg.
Oh,
Yeah.
okay.
Hand
That
surgery.
region
Yeah.
of the body.
Gotcha.
There we go.
Okay.
yes,
Okay.
yes, good clarification. Good clarification.
But West Coast sounds nice.
I know.
West Coast anesthesia.
But many of us do many different things. And so I do a lot of obstetric anesthesia because I'm in academics, and that is what I was recruited into my position to do. So a lot of women's health anesthesia.
And tell us a little bit about what that looks like. What does an obstetric anesthesiologist do on a day-to-day basis? You come into work, and what is
in.
on your list for the day?
So if I'm on labor and delivery, where I'm going to do at my current place of work only obstetric anesthesia that day, we're going to take sign out of the board. So the team that was on during the night is going to tell us about all of the patients that are on the board. And what many people might think is that ends with who has an epidural and who doesn't have an epidural. Because what a lot of people think is if they don't have an epidural, that I'm not
you're
involved
not
in their
involved.
care, that I don't even know that they're on the floor.
But no.
But
You're in the
no,
wings.
No. If you had been trained by me, you would hear me say, all of the patients on this floor are our patients. Because I think a lot of people don't realize that at the end of the day, if something gets complicated in a patient's care, or if something starts to take a negative turn, maybe there's an allergic reaction, or maybe someone with preeclampsia turns into eclampsia and they have a seizure and they're having trouble breathing. All of those events come down the line to anesthesia. And so if I'm meeting that patient in extremis for the first time,
Yeah.
it's not a good look. And
Right.
I might not have all of the information that I need to care for her in the best way possible. So we see everybody that comes onto our floor, even patients that have already delivered, which I think that can be really confusing to a patient, especially if someone is celebrating maybe a birth center delivery where they absolutely did not need our services.
Yeah.
We celebrate that too. Like that is hard stuff right there. But when you come into the hospital, there's usually a reason for that. And we just want to make sure that we have all of the data to keep you safe if anything bad were to happen while you were in-house.
Yeah.
So do you go introduce yourself to those patients, like as the, doing rounds, letting them know you're there?
Yep. We
Okay.
take a full intake.
Okay.
And we'll talk about simple things like if you've ever had anesthesia before. Has anyone in your family ever had trouble with anesthesia before? Do you have any allergies?
Right.
Do you take any medicines for any issues when you're not pregnant?
Okay.
Just very simple medical background questions.
Well, the people that you're like getting the handoff of the board, will they have already asked those patients that same question, and now you're going to come in and
We
ask them
won't-
again, or how does that work?
Yeah, that's a good question. We won't go back and see them again. We
Okay.
won't keep bothering them
Okay.
every
So
shift.
okay.
The 8th time. What's your allergies? Patients love that.
That's what I was going to say. Is
They
like,
do.
oh,
Yeah.
that doesn't sound fun.
Yes,
But okay.
yes.
Okay.
Wake them up at 3
Yeah,
in the
right.
morning.
All bright-eyed and bushy-tailed, and you're like,
Yeah.
I just had a baby. Yes, I've
And
done
you
that.
said you were a Scorpio? No.
How do you feel about that? Yeah. No.
Yeah, no, we won't do that. We won't do that. We have a way of transferring information
Okay, great.
safely. Only information that we really need to
Sure.
take care of somebody.
Sure.
And so we keep it in our medical record system.
Mm-hmm.
And if there's anything pertinent, if we found out that someone had congenital heart disease and had surgery on their heart when they were younger and made it through their entire delivery and
Didn't tell
nobody
anybody.
knew.
Yeah.
You would be surprised how many times
Oh,
my little
that doesn't
residents
surprise me.
get in here and find
Dig,
out
dig, dig.
information.
I Actually, wouldn't be surprised.
Yes.
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 I've been surprised before. It's not a great
Yes.
feeling.
So that's the day that you're in the hospitals. Is there ever a time where you're not in a hospital, like where you're in a clinic setting, or is that or where else do you guys show up?
Some of us, myself included, rotate through ambulatory surgery centers.
Okay.
So
that's like the
if-
same day patients kind of thing? Okay.
Yeah,
Okay.
exactly. So if you're having a colonoscopy or if you're having a cataract or if you're having minor plastics procedures.
It's like lots of stuff is same day surgery now.
lots
Which I'm
of
like,
stuff.
whoa, gosh.
Yes.
This is
Yes.
so much.
Absolutely. So you could see me in an outpatient setting. That being said, it's not going to be a clinic.
Okay.
There will be
a
operating
surgery center.
rooms
Yes.
and procedural suites. Yes.
Okay. Do you ever go through the ICU? And do you ever follow a patient to ICU, or is it a handoff situation?
I may go up there if we're having a delivery
Okay.
of a patient in an ICU setting, which is pretty rare but becoming more common.
Ooh.
And we can talk about that
Yeah,
a
I was
little
gonna
bit
say,
more.
Ooh.
Yeah.
Just to write that
Yes.
down.
So I may go up there, or if I'm having a day where I'm practicing general anesthesia in an operating room, I may pick up a patient
Okay.
or drop off a patient.
Okay.
Or if I'm on call and the call team is busy and there's an airway that needs to be secured, I may respond to a request
Okay.
for an airway as well in an ICU.
Okay.
Probably most people don't know, Courtney, that a lot of the code teams, when there's a code blue, have an anesthesiologist in that team.
Okay.
Yes.
So you're always
Because they are the best and most skilled usually at your airway and difficult IV access and things like that. Yes.
okay. Yes. No, I didn't know any of
Those
these
are-
things.
Yep.
No. You were the number one person that I wanted to see as soon as when I was, in my experience, my first surgery that I ever knew. I had C-sections, but no offense, I didn't count those really as true. I know they are true surgeries, but
Wow.
I was never being put.
Shade.
I was never being put under. So
Right.
this was my
You
first
had
time
regional.
to like. I did. Look at that.
Look, you know what they
That
call
didn't
that.
work, and then I had to get more, and I had
no.
propofol, and I was very
Good
terrified of that because it was recently after Michael Jackson passed away, and
the buzzword was out. Yeah.
I was like, isn't that what Michael Jackson had? And this hand on my shoulder was like, that's not going to happen to you. And I was like, okay. Anyway, it's a whole story I could tell you, but I'm sure you've
Michael
heard it
didn't
1,000
have
times.
me there.
Well, okay, right.
needed you there.
Right.
I don't know that he had a code card.
I know, yes.
Definitely not an anesthesia provider.
Right. But they like parade all the doctors in front of you. Everybody who's going to be your doctor just gets introduced to you. And that's very overwhelming. For me, it was like they were like, do you normally have high blood pressure? I was like, I do not, but this is freaking me out. So my number one question was to find the anesthesiologist. And it was kind of a crazy story because I'm a redhead. Don't you know
Yes.
this? Yeah. Yeah, true. But is that a thing? Is that real?
The myth
Oh, it's
behind
a
the
great
redhead.
question.
Oh,
Yes,
no.
what a good question.
I think if you talk to enough anesthesiologists, you may get some people to say yes.
Okay.
Sure
Get some
thing.
people. Okay, I hear what you're saying.
Wow, what a very fair statement.
I don't think that the science has really borne out anything that we can,
Okay.
stake a claim on.
Okay.
But I do know a lot of people that come in and tell me that they've been told by other anesthesia providers that it was because they
have red
had
hair.
Yes,
It's
I
always
had
best
an
to blame the
anesthesiologist walk into while I was in labor, and he was gonna do the epidural, and he literally said, "Oh crap, another redhead."
Oh no!
And I was like,
no.
and the nurse was like, don't freak out, he's really mean, but he's the best anesthesiologist, so
really
just
mean.
don't argue. Just don't argue. I was like, great. But yeah, that was a different experience. But
I'm sorry about that.
that's okay. So what? That's not what
You're
we're
here
talking
to apologize for your
No,
entire
you're
field.
not. No, you're not. That's not what we're talking about. So you're in the hospital most days, or in a surgery center. Do you have an office? Do you like do paperwork and all that lovely stuff that I
Lots
keep
of
hearing them talk about?
I do. I am also an administrative leader within our team.
Okay.
And so I do have an office.
Okay.
And I'm in there occasionally. It is very close to the workroom, so even when I'm working,
Mm-hmm.
I can pop into my office
Okay.
and answer some emails or meet
Okay.
with somebody that needs to be met with.
Okay, great. Awesome.
What is the biggest change you've seen in your specialty over the past 10 years, would you say? Or biggest changes? I know there's been a lot that has happened in medicine.
Yes, I think probably just the overarching distrust of medicine.
Yeah.
I think has really boiled down in anesthesia.
Really?
What do
Yeah,
people
what is
say?
it?
Yeah.
Well, because we were associated with the pandemic in such a big way,
Really?
right? Because people that were in the ICUs,
Oh.
people who were having trouble breathing,
Okay.
who ended up needing help with that
Yeah,
breathing.
needed your help. Yeah.
Many of the people that were still interfacing and performing their jobs in a very regular way were ICU doctors, nurses, anesthesiologists in the operating room. And so I think that we're a face that people very closely tie to that time. And, many people still to this day have very different feelings about that period of our history.
So you feel like they
And-
don't trust you? You feel like they don't, maybe are more hesitant to?
Well, I think it's additive because
Okay.
so much of like what you said, even my own mother, when I told her I was going to be an anesthesiologist, she's like, "So you just put him to sleep and you leave?" And I'm like, "No,
And go home and have a nap.
no, no." But it's a very poorly understood field,
Okay.
right?
So what do you actually, so let's talk about what your mom just said. Like,
yes.
what do you do? I'm going in for surgery. You meet with
Yes.
me beforehand. I meet you. You tell me to count backwards. And then
Which we don't really do most of the
Okay,
time.
okay.
In
Myth
the
number 2.
Okay, there we go.
in Grey's Anatomy,
Redhead.
maybe.
Oh, okay.
Okay, backwards.
But so you get a patient to be comfortable and asleep as much as they're supposed to be, and then you...
If we're doing general anesthesia.
Right. Okay.
Yes.
And then
yes.
you fill in the blank.
And then we are inducing general anesthesia. So when you're going to sleep, we call that an induction of
Okay.
general anesthesia.
Okay.
And that's when we drift you off to sleep. And then after you drift off to sleep, we have to make sure that we have an airway because you're not capable of holding one on your own.
Okay.
And so we place a device that will help us to do that.
Okay.
And then sometimes, depending on what the surgeon preference will be or what the surgery requires, we can let people breathe on their own with that airway in place. Or we might have to breathe for them, and we use a machine called a ventilator to do that.
Okay.
Breathing devices go in your throat,
Yeah.
which is a really stimulating area.
Yes.
And so people need to be asleep when they have those devices in.
Sure.
So we maintain anesthesia with either IV meds or inhalational meds that go through the breathing device, or a combination of the two of those.
Okay.
And we can do that for however long the surgery takes.
Okay.
And then we start something called emergence, where we pull everything back slowly,
Yeah.
make sure that you're breathing on your own and that your vital signs look good
Okay.
and that you're capable of protecting that airway when we take out whatever device we have in, and you wake up.
Okay. So you're constantly monitoring a patient.
Yes.
Are you watching like brain waves? How do you monitor somebody's?
So there's core vital signs that we monitor for every surgery. Things like blood pressure, heart rate, how
Okay.
your oxygen saturation is.
Okay.
But there is a monitor that sometimes you may see on if you've
I
ever
have had glue on my forehead
There
when
you
I woke
go.
up, and I
There
was
you
like,
go.
"What was this?"
So it's the glue,
just
and it's
watching your
very
brain.
salty. Yeah,
Yeah. Well, I didn't lick
you
it,
didn't
but
taste
you
it?
know, I didn't.
and we
Laura's
can watch
tasting it.
brain waves.
Okay.
To keep it very simple, we can watch
Yes.
brain waves, and you can think of it when you're sleeping. You have different patterns
Sure.
of brain waves, and so when you're under anesthesia, you can also have different patterns.
Okay. Okay.
That rolls into a question we were going to ask
Yeah.
about consciousness under anesthesia, which I think scares a lot of people. Is that a real thing? Does it happen often? And what are the things
You mean coming
do?
awake while
Yeah,
you're
like,
being awake.
under? Oh,
Yeah, but still being
Yeah.
paralyzed so
Ah.
that you can't. So there's
I hadn't even. Sorry, I thought of that. That's
now
horrible.
you have a nightmare. Yes, well, I used to would hear
it's
it.
very rare.
Yeah.
It's very rare. And we have lots of safety mechanisms
Mm-hmm.
to make sure that somebody is truly asleep when we want them to be asleep,
Mm-hmm.
right? I think some of the stories that have been passed down and, talked about are the fault of our field for not explaining things properly. I'll give you a great example that I have to talk about almost every time I'm at a surgery center. People say, "Oh, am I going to have to watch my colonoscopy this time? I had to watch it last time."
What?
And I'm like, "Okay, no."
My neck doesn't bend that far.
Yikes! How could you even on
But-
the screen? I guess.
Yes.
Years ago, we did not explain to people that there was a choice, right? You could have your colonoscopy under midazolam and fentanyl,
Okay.
or you could have your colonoscopy under propofol. If you have it under propofol, that's an induction agent. So we can induce general anesthesia with propofol. Okay? It's a very different experience. A much deeper plane of anesthesia can be obtained with that.
Okay.
Those two other medications are great medications and they have their uses. And some people will sleep through a whole colonoscopy with those two medications,
Okay.
but some people will not.
Okay.
And it used to be that there were certain insurance plans that would only cover one way.
Ah.
And so we
There
didn't
it is.
explain to
Yeah.
people, you had this, so you could expect to feel this, right?
Okay.
And so I have to clarify that to people, and they're like, "Oh,
Okay.
well, I wish I would have known that. I've been
Yeah.
scared every colonoscopy since then."
Oh.
And so I think a lot of education goes so far.
Yeah.
Yeah.
Do surgeons ever ask you to keep? I have two questions to this.
Yes,
Do
go ahead.
surgeons that shall not be named? I'm just kidding.
we are perfectly well behaved.
I
in that
know.
order.
Do they-
And
do
make
they
no
are.
demanding?
Is there ever a time when they want a patient to be awake-ish, like to sit up, to do something,
Yeah.
and you have to bring them back up, and then they do whatever it is that the patient that the surgeon wants them to do? I'm thinking of plastic surgery or that kind of situation.
Yeah.
Like, you make sure
Yeah.
things look right when they're sitting up and not just laying down.
Yeah.
Is that true? Does that really happen?
Oh, for sure. For the plastics part, I'll answer that first.
Okay.
We are not going to wake them up for it.
Right.
If
just
you
going to-
want to talk about breast surgery,
Yeah.
right?
Yeah.
Gravity matters.
Sure.
Right?
Yeah.
Sure.
Yeah.
So you're going to want to know that it looks
Symmetric?
great laying
Yes.
down, sitting
Sitting
up,
up.
turning
Yes.
sideways,
Okay.
right? And so we will change the position of the bed during many of those
but you
cases.
don't take them out of
No.
any kind of but are there other times when you do
Yeah.
because it's
Yeah.
helpful to the surgeon?
Absolutely. So different neuro or brain surgeries sometimes are done with the patient completely awake.
Yes, those are the things
Because-
we have nightmares about.
But it's
You need it
actually
to.
It's needed,
it's
yeah.
possible to have one of those surgeries and have the patient be totally comfortable, relaxed. We get the information that we need for it to be a successful surgery,
Right.
and everybody looks back and says, "Man, that was a success."
Do you have it? My second part of that question. Do you really have a medicine that wipes people's memories?
We do have medications that interfere with the formation of memories.
Ah, okay. So you get it on the front end, and then if anything is you
Well,
don't
we
know?
have some that are anterograde and then some that are retrograde.
Okay.
So it depends. There's
Okay.
different agents for everything.
Yeah.
It's never our desire to say, "Oh, we just need to erase everything."
Yes.
Right? That
Right.
nobody sits around
Right,
and
right,
talks
right,
like
right.
that.
Right.
But there are different experiences that I've had in medicine
Yeah.
where I'm so grateful
Yes.
that I don't
Oh,
remember.
for sure.
Oh, yeah.
You know,
Like the last thing I remember is you telling me to get to that bed, but
Yes.
I don't remember doing that. I assume I
Yes.
did, but and I
Right.
assume I did it myself because I know that's one of the big, hurdles to
right.
like moving a patient. That's hard to do. So I remember them being like, "Put your head and your leg on these purple things," and I was like, I remember being told, do not remember doing it, but still
Yes.
had the surgery just the same. So,
Yes. And many people, if we give that medication, will be like, well, I don't know if you gave me that medicine because I don't remember this part last time. And I want to say you're not going to remember it this time either. But no one ever believes you when you say that. So it's just like,
guess I will.
oh, we're going to take great care of you.
That's funny.
Moving on.
That's funny.
What scares you the most in your field?
Oh, man.
It's a therapy session
That's
now.
a
It starts now.
It's a therapy. There are so many scary things in anesthesia.
I know,
'cause
yeah.
A lot
All
of
medicine,
times you
but
guys
yes.
are the, at the really critical junctures.
Yes, fixing
You guys
these
are the
problems.
ones who are there.
Yes. I think that it's not having enough hands. Because we are in this time where resources are so short.
Are you usually alone?
I'm not.
Okay, so
I'm
you have who's
hardly-
with you when you're
It depends.
in a
That's
surgery?
another great question. So I will always have at least one in-room provider.
Okay.
And so that can be an sRNA, which is a student studying to be a cRNA, which is a certified registered nurse anesthetist.
Okay.
Or I could have a cRNA,
Mm-hmm.
or I could have a resident, which is a physician that is doing their residency in
To be
anesthesia.
what you are.
Or I could have a fellow
Okay.
as well
Okay.
in that room.
Okay, but you would never by yourself.
I will never, can't say never.
Sure, okay.
Because where I used to work, we did set our own cases. But with shortages being what they are, and you can just have one anesthesiologist run more rooms and accomplish more
Gotcha.
medicine
Yeah.
in the model where there's a team approach.
But the anesthetist could be alone with
Okay.
the patient.
Okay.
Yes.
Is that like a handoff situation? Like the anesthesiologist gets it going and gets everything to the place where everybody's comfortable, the surgeons feel good, everybody's good, and then the anesthetist kind of takes over and monitors?
So we are there for induction and emergence.
Okay.
So remember the beginning and the end. And then anything where there could be higher stakes, so we're moving positions like you talked about, or I'll give you an example in cardiac surgery if we're going on and off pump for cardiopulmonary bypass.
Yeah.
Or if anything is just not going normal or smooth, like the blood pressure's too low or too high, or the heart rate's too low or too high, or our oxygenation levels aren't where they should be, then the anesthesiologist will come back into the room.
Okay. Okay.
I've definitely been in situations where I've asked the anesthesiologist to come back because
Same.
we're having bleeding or something's concerning from my end, and I'm anticipating we're going to need a little more attention,
Okay.
and we might need blood, or we
that
might
a-
need some help.
Pager situation? Is that a call over the intercom?
We
like,
have
what do we do?
multiple ways,
Okay.
multiple ways of finding out that we need to come back.
Is that I open the door? Come on in. Come back. Come back.
I mean,
People
I have seen that
run in the
too.
hallways to get some help.
And that's the great thing about most settings that are surgical in nature is that the teams that are built, most people know everybody. You know, there's very rarely somebody that doesn't have my phone number and my pager number and knows how to call overhead. So we're a really tightly knit team. And if it's my in-room provider calling me back, or the circulating nurse, or the surgeons, or the residents, it would be all the same to me because we're all, looking for the same outcome
Yeah.
and want to take great care of the patient.
So that's what scares you the most is being
No,
Not having
man,
enough
that
hands.
not
really
having
went.
people.
I know,
Sorry.
that's
No,
okay.
I just
That's
wanted
fine.
to
a different way.
Not having enough hands, you said.
Yes.
For example, I had a shift recently where it was just so busy. Okay, so on labor and delivery, I have a team, myself being the only attending that's on if it's a call shift. And then I had 2 residents, a CRNA, and an sRNA with me. And we had 3 very sick patients that were in the operating room. And then we also had sick patients that were in labor and delivery rooms.
Oh, no.
And 2 of them were flirting with needing their care escalated.
Okay.
And I did not have the ability to be in 5 places at once.
Yeah.
And while I knew exactly what I needed to do
Yeah.
in all of those locations, we called for backup, and those backup teams were also saturated.
Okay.
And so everything ended up going well, and you just keep moving along. Just
Yeah.
like Elsa says,
Yeah.
what's the next right thing?
Right.
But there are more and more times in healthcare where we are being asked to do very, very critical care medicine with less people resources and less like physical resources too,
Okay.
right?
Okay.
Especially in anesthesia and surgery, we do so many things with plastics. This oil situation, the number of emails I get every day saying like, hey, we can't make the plastic for syringes
Yeah.
or
Oh, yeah.
because we
Yes.
don't have,
Yes. Like,
supply chain.
right. Ugh. Yuck.
Yeah.
Okay. That's
So
scary.
I think that scares me because it's not getting any better.
Okay.
Yeah.
Okay.
On that note, if you had to give patients in general, all of America and the world, one piece of advice about having anesthesia or having surgery, if you could say, this is my advice to you, what would you tell them?
Probably what I told myself.
Before anesthesia?
Yeah, before I had to have surgery. So I think what makes having anesthesia hard is that you have to give up complete control.
Yeah.
Yeah.
You have to give it up in its entirety, but you also have to do it with somebody that you have never met in your life. Most of your patients have met you guys, right?
Right. Yeah.
And you have
Have a
a
relationship.
nice little relationship, and they've never seen me, and I have maybe 5-10 minutes maybe for them to
Trust you.
decide that they can put their actual lives in my
Yeah.
hands.
Right.
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 And so it's a challenge that I really like. I like trying to make a really meaningful bond with people quickly. I think that's why I like obstetrics so much. My patients are usually awake, and it's either the best day of their lives or really like one of the worst.
Yeah.
I love that intense relationship that you form with someone. I think it's beautiful in like many, many ways.
Yeah.
But I would say that you need to trust and really work on giving up a little bit of control and trusting that the person that is going to take care of you has your best interests at heart.
Yeah.
Yeah.
It's hard to
I know
believe.
that's heavy because I was not very good at it myself. Yeah.
Well,
It's
you
so
know
true,
too
though.
much.
It's good. Yeah.
You know too much as an anesthesiologist.
I do,
that you're like,
but I think also, and we could go down a whole nother pathway of pain in terms of anesthesia, but I think the experience of pain or the experience of anything in healthcare is so shaped by other experiences that you've had up until that point of your life.
not just medical ones, but outside of medical ones.
Everything.
Okay.
A lot of trauma.
Sure.
Right?
Sure.
A lot of trauma, you really see it come up when people are entering medical
Yeah.
situations.
Well, it's like ground zero for all of life, Like,
Absolutely.
is this over?
Absolutely.
Is everything
Right?
ending right now?
Yeah. And
Brings up all
how,
those things.
think about when you experience pain. If it's something and you can say, oh, if I can just get through this, I know that it will stop and I will feel better. But labor, for instance, where I'm around all the time, it's just going to keep happening
Yeah.
and
Oh, yeah.
happening
Right.
Oh,
and
yeah.
happening.
2 minutes later.
Yes.
Right. And I think that the loss of that control or like the inability to see the end of it, people who have had trouble with trauma in the past, those people have a harder time coping with the pain of labor. And I don't think that I don't think that that's any fault of theirs, but that's
Yeah.
something that we don't think enough about,
How
right?
trauma informs their patient
Right.
experience.
And what
Yeah.
could we do better to
Okay.
make that easier for them?
That's good.
So I try to say things like simple things. This is going to be one of the last bad contractions that you feel. You've been doing this for so long, but you're almost there.
Yeah.
Right?
Okay.
Because I think it sets up a perspective of it not just being this like forever situation that somebody's forced to sit through.
Sure.
When I do an endometrial biopsy, very different than labor, but some would liken it to that. I
Yes.
count down from 10
Okay.
so that they know, as opposed to counting up, I count down. And then they know that when I've done,
Yeah,
when
you
I
get to when
to
that's
zero,
done.
it's done.
Yeah, okay.
Yes.
Yeah,
they know
that's a great
where the
idea.
end of it is.
Yeah.
Because it's very uncomfortable, but I need a good sample.
Okay.
So I count down from 10.
Okay.
Right.
Interesting.
Is there any threat to your field with AI?
Ooh. So many exciting things happening with AI. I don't know that it will ever be a threat. I think it's going to be really helpful. Maybe that's too optimistic or rose-colored glasses for me to say, but can I give an example?
Yes, please.
Yeah.
We love
Yes.
examples.
So right now, we have an uptick in maternal mortality in obstetrics across the United States. Not a secret. It's out there and it's very true. We could talk all day about why it's actually happening, multifactorial, but hemorrhage is one of the things that continues to kill women in
Yeah.
childbirth.
Yeah.
And one of the things that one of my brilliant colleagues is doing is developing an algorithm that helps predict risk of hemorrhage in childbirth. And you might think, oh, well, I think I've heard of that happening before. You have, but the risk factors that we used to think were the most impactful might not be the ones that we really should be paying attention to. We may have been missing some. And we also have some factors that are dynamic, like if a woman gets an infection in her uterus across labor, right? That's not something she came into the hospital
you
with.
didn't know ahead of time.
It's something that happened across that labor course. And so this tool that she's developing with AI is reflected on our board that we sign out, and it tells us across that woman's labor curve, because we could have 30 people laboring.
Yeah.
It says, hey, room 8 is now an extremely elevated hemorrhage risk. Do you have the appropriate things in the blood bank? Do you have the appropriate access in her? Have you talked to her about what it would look like? Would she be accepting of blood products? All of those things that, not that I would have missed those, but when we're watching an incredibly busy
Yeah,
board,
that's so helpful.
it's so helpful, right? And so that could be life-saving. And so I think that it's going to be a tool for us in a setting where we are resource poor.
Yeah.
I think it's going to help and kind of seal in some of those cracks.
Okay.
So I'm excited about it.
I think they're doing something similar in some ICUs across
I'm
the
sure.
country looking
Yeah.
for early markers of sepsis
Yes.
before it develops.
Interesting.
And so they can catch it, and AI is pulling from the chart,
Yeah.
and alerting the team even before things like a temperature goes up or a white count goes up or a blood pressure drops. Early markers.
And look at radiology.
Oh, right.
AI,
Yeah, big impact there.
man, it's made a huge impact. Huge impact.
Speed of results and
And
looking
just
closer.
the ability to see things that maybe the human eye can't see.
Especially when you're tired.
Yes.
I feel like when I'm tired, the first thing that goes is my eye.
Yes, right? Right? You're like, why is it
Says
blurry?
the
What's
surgeon.
happening?
I just got fired.
Yeah, that's awesome. Whoops.
Yeah. So
That's great.
speaking of things that I could get fired over, when I was in med school and actually in undergrad, there were things that I had to take that I was like, I'll never use this, and it's a good thing because I suck at this, like organic chemistry and
Oh, I love
pharmacology.
organic
See, look, this is
chemistry.
where I'm going. Good. Yeah. So there were definitely things I was like, I'll never use this, and then I'll be in the OR with you guys, and I'll hear you jabbering away all your little things, and I'm
About
like, they're using
PKAs.
all of that. They're using all of that chemistry. They're using all of that pharmacology that I just threw in my trash, my brain trash. So, do you think that anesthesia as a field definitely taps into more of those early courses that a lot of us just take, make the grade, and then flush, or no?
I'm trying to think of it as a comparison to other fields. Maybe more the chemistry and pharmacology.
Yeah.
Yeah, I'd never thought about that before, actually.
See, you were like, I love that. There you go. Self-selected.
I actually taught organic chemistry.
Oh,
Did you
wow.
really?
I was a TA.
Oh, that's fun.
Whoa!
I loved it.
I bet you were great at that.
But I like love puzzles.
Oh, yeah, how it
So,
fits together. You
yes,
flip
I
it,
love
the chiral.
puzzles.
Yeah,
Yes.
no.
I can
yes.
see that. That's
We talked a little bit about this with COVID, but social media in general. Do you guys get do you feel some heat on you from social media, or some trends that have happened in anesthesia from social media, or just questions that you get that you're tired of answering over and over because they're popular from an
Somebody saw them on
influencer?
it, yeah.
Yeah. Has that kind of moved into the anesthesia realm?
Well, it did in the recent past with Tylenol
Oh, yeah, sure.
Yeah.
in use with pregnant mothers. So
Oh, yeah.
that became very trendy and kind of a hot button issue. And so there was a lot of situations where we wanted to give a patient Tylenol. They desperately needed Tylenol. They were infected, high fever, not a good environment to be pregnant.
Yeah.
Right?
Right, yeah.
And they were reticent to take the Tylenol. So that, the simple things like that bleed through. And then also, I don't know if you guys would have felt it as much as we did in anesthesia, but there was an article that came out that made the accusation that epidurals contributed to autism.
Oh, I didn't.
Yeah.
I didn't hear
I
the
missed that.
epidural part. I
I'm
thought the
trying to think
vaccine,
about
but-
how long ago that would have been now. Probably years ago. Time's flying. And a lot of the larger societies within my field, so, within you guys' field, ACOG, and then SOAP is the Society of Obstetric, Anesthesia and Perinatology, and then the American Society of Anesthesiologists had to come out with statements and respond to the journal that published the article that, everybody has their views about how publications are selected in different journals, and I'll leave that there. But I think that I know, and you guys know, that a lot of those societies take into account all of the publications and all of the research, and which research was done rigorously and was vetted appropriately and had the right statistical analysis. And it's hard for the lay public to know that, right? Like, if I wouldn't have gone through all of the years of school that I've gone through, it would be impossible for me to interpret the scientific literature,
Sure.
right?
Yeah.
Sometimes
An
I
entire
still
body.
don't know how to
Right.
interpret certain statistical analyses, right? But I know who to ask, and I know how to think about something being worth my consideration and something not. And so when things get very buzzy and trendy in social media, the blowback of that, and we don't have a lot of time to prepare, right?
Right.
I think that SOAP, which is our main society, they responded like within 24 hours because they knew
Yeah.
that it was just going to be.
Oh, but yeah, they had to get ahead of it.
Oh,
Yeah, that would be bad.
absolutely. Just because they wanted patients to feel like they had the data to make the right decision for them,
Yeah.
right?
Yeah. We talk a lot. We try. One of our main goals is to humanize doctors, because often as a patient, you feel this wall between you and the doctor. And maybe a doctor that you go and see in a clinical setting is different because they care for you over a longer period of time. You mentioned it. You have 5 to 10 minutes to like build trust with someone. Do you feel, talk about how, if you feel the weight of what you are doing with patients, like you're a human, so I'm assuming you do. And you went into it to care, you went into being a doctor to care for people. That was your, you answered this call that you had on your life. But what
do you take with you?
Yeah. How do you feel when you leave the hospital? What does that look like?
I think, man, I feel like it is such a privilege with what I get to do every day. And I think that, I'm a believer. I don't know that all anesthesiologists are believers.
Okay, sure.
But
sure.
I do feel like there are these moments that are very holy moments, right? And people will show emotions right before anesthesia, right after anesthesia.
Yes.
The number of patients that ask for someone to pray with them before they go to sleep, it's really profound, and it crosses all lines, like different people in the operating room, different beliefs, different ages, different genders, everything, right? And I feel like it's a great equalizer because I get to see people in their most human, basic form, right? I don't know the road that they walk to get to that moment. But I've done it long enough that I can see that everybody is the same, right? We all bleed the same blood, right? We all experience the same pain. We're all scared of the same things, right? I've cried with so many different kinds of people, right? There's been high highs and low lows, and to be able to share those moments with people, like I don't take that for granted,
Okay.
It's
very sweet.
Yeah.
It's very sweet. I'm like crying here.
Tissues.
Yeah. Yeah. I wrote a paper one time. I don't know if you've ever seen the movie Philadelphia. You ever seen that movie? It's
The Tom Hanks movie?
Old
It
Tom
sounds
Hanks
familiar,
movie.
yeah.
He contracts
AIDS.
HIV/AIDS. This was way in the early, like when that was an absolute death sentence, like almost immediate.
Yeah.
Anyway, he was a teacher who we got close to, and he passed away from lung cancer. And they let a bunch of teenagers, I don't know why, go up there and see him in like his last days. And that was extremely impactful as a 16-year-old. And so he was shriveled up in this tiny version of himself, no hair, pale as all get out, big dark circles, and struggling to breathe. And then I was in like a class, and we were watching Philadelphia, and I'd never watched that movie before. And that is exactly how Tom Hanks' character, who lived a very different life than my teacher, my teacher was, just a normal, regular guy. But at the end of life, they both looked the same. And that was a profound moment. And I feel like that's what you're saying is like when you get that close to birth and death, there's a lot of equal playing fields that we all come to, and that's
Absolutely.
That's impactful to hear.
Absolutely. Absolutely. Yeah.
Well, on that note,
To flip the coin to the other side
totally
of
going
something more
to.
fun.
yeah, I think actually we're going to move on to our last part, which is speed rounds.
Oh boy.
Yes,
Rounds.
rounds. It's our pun. The rounds,
Medical fun.
which we'll go through. And so these are just sort of short answers. They don't have to be one word or anything. If we
Okay.
want clarification, we'll ask because sometimes it's nice to know the context,
Backstory.
the
Okay.
backstory. But yeah, just you kind of off the cuff things. Are you superstitious?
I don't think so.
Oh, I thought for sure you would be.
I don't think so. No.
Okay, good for you. Fine, live that way. Which other specialty do you have to ask for help the most from?
I I think OB, just because
You're there.
I'm there the most. Yes, absolutely. OB and GYN.
Not leaving us out.
You both are obstetricians, right?
I mean, yeah,
Yes.
we're
Sort of.
reformed.
Not
or-
practicing.
Yeah,
Retired.
emeritus.
Paused.
Healed.
Non-denominational.
Non-denominational. I'm gonna start calling myself that. What's a word or phrase you end up saying multiple times a day?
There's so many.
That's what I think we all get these little scripts that
Yeah.
we say over
Yeah.
and over again.
Yes. I think if one of my trainees was here, they
Yeah.
would tell you that I am always saying, "You're safe."
Mm-hmm.
I say it when someone's waking up. Even if I know that they're not conscious yet,
Yeah.
I will start saying it way before I think that they are, just because I want them to truly feel that way.
As soon
Right?
as they're
Yeah.
awake.
Or if they are awake in a C-section, you know, I say it all the time. You are safe.
That would be very reassuring.
Yeah, that was that little tap on my shoulder. I'm telling you, that man just put it on there, didn't take it off. It was nice. It was very nice.
Good.
Who in your inner work circle could you not live without?
Oh, I mean, so many people. I am so lucky. It really is a family that I work within, and we were just at our national conference, and so many people came up to us, and they were like, "Man, you guys have a really great thing." And I just feel like I practiced amongst some of my closest friends. And it's because when you practice in medicine, you go through such intense emotions that it forges these bonds, right?
Yeah.
My husband is always like, "Man, I don't have friends in my office like you have." You know, like I would never tell the guy that sits in the cubicle next to me what the people at your work know about my life, you know? And it's just, but it's such a beautiful thing too, because I get to come to work and do amazing things with people that I really, really am lucky to be around. So I can't name just one.
Okay, we'll let you slide. All right, this next question's for the med students in the audience. How many hours a week do you work?
Okay. Like clinically?
Like, every time you do something that's work related.
Because I wear an administrative hat, oftentimes
that's added.
when I leave work, I am going to go home to my mom job, and then after that job, I'm going to do a little bit more work.
Yeah.
And that can happen on the weekends as well. And I think a lot of people are like, "Well, you need to learn how to draw a line in the sand and make boundaries and, you know, decide that you're just not going to work on your day off." Some of it I do because I know that it makes the days when I'm at work
Easier.
digestible.
Yes.
Right?
Right. Yeah.
And so I think it's an important thing for these medical students to think about, because when I was deciding what I wanted to do, I did not think about hours or if I was going to have a clinic or what if I wanted to write notes. Actually, I did think about that. I hate writing like long notes. So that
So no internal
That
medicine
fit.
for you.
yeah, that's a good thing with anesthesia. Our notes are very short, succinct. Only the most important
To the point.
details. Yes.
Okay.
She didn't give
great
you a
point.
number.
I know. That's okay. I mean, I have an idea. If that's all right. She doesn't have to answer that. If you could ask your boss or chair for one thing, what would it be? And they had to give it to you.
Just because she doesn't want to
That's
answer
a
that
tough
question.
one. I'm not following the lightning round rules.
That's okay.
Oh man.
Can be big
There's
or
so
small.
many.
Like
There's
I would
so many.
love
That's
some
what to say.
creamer in the surgeon's
That's what to say.
office.
Oh, right. Yeah.
Really?
Is it not
Snacks.
something anesthesia techs?
Snacks.
Yeah. Well, I'm just thinking in my mind, I'm like, well, I could ask for that, but like, that's not his it's not
he
his
could've given it to
problem
you?
that he
Yeah, he
doesn't-
could fix it
he
for
can't
you?
have it,
Hi,
right?
this
Right,
guy.
right.
Let's
right.
see.
I think inpatient interpreters
Oh.
constantly. I
yeah.
want every
Yeah. That's a good one.
person that needs an interpreter. I want a live
Person.
human being there the whole time.
Ah.
Yeah.
That's so
Yeah,
great.
because going into
Such a
the OR, then
difference.
it's already so stressful, and then if you didn't speak the
Oh
language,
my word.
yeah,
That's horrible.
another
quicker.
layer of complexity.
Yeah.
yeah, and fear.
I did a couple weeks ago. I did 7 cesareans, and 6 of them I needed an interpreter, and it was 4 different languages, and none of them were in person, and multiple disconnections. Had to call back, and I just feel for the patient
Yeah.
because I can't imagine. Well, I mean, we can all here imagine what it's like to do a surgery in your own language, but then
Yes.
imagine in a
Right.
different language.
Right.
Yeah,
No
right.
way.
In a foreign
Holy
country,
cow.
yeah, I can
Trust
imagine having to
of
go
that.
somewhere
Yes.
and do that.
Yeah.
That's an excellent answer. What other medical specialties gross you out? Just FYI, your specialty grosses us out.
Been mentioned multiple times.
Oh my gosh, because of saliva?
Yes. Yes, but it's so much more
exactly
than
it.
that. It's the amount and
I
like
mean,
the
you have
stringiness.
some nerve.
Gynecologist.
We fully admit that is a very
With the
bizarre
amount
comparison.
of things that I've seen you with your
Suck out
hands
of
in.
people. Yeah.
Some nerve.
Hair, teeth, like, I mean.
Okay. All right. So good. Judgy.
Okay.
All right. What grosses you out?
I cannot do injuries to the nail bed, whether it's your
Oh, that's a good
toenails
one.
or
That's a
your
good one.
finger.
Ooh.
Yeah.
I'm not even
Yeah.
going to talk about it anymore because I can't.
No hand. Okay.
Nope.
Yeah.
Ooh, no
Yeah, no,
way.
could
so
never
I
do
guess
podiatry.
podiatry,
Yeah,
I
podiatry,
can't
no.
do
Oh,
that.
it
Yeah.
smells like feet in there. We're gonna get a podiatrist on here, and I'm gonna ask that question.
We're
'Cause
gonna
I'm
ask
like,
all the
one time
questions,
I
like,
went, I was
why,
like,
dude?
this entire
clinic.
section of the hospital smells like feet. What is happening? It was horrible. It was horrible. Horrible.
Okay. Okay.
Now we're never going to
Side
get a podiatrist.
Side note.
Yeah,
When I went to cardiology one time because I had a weird thing happening, that waiting room, every person in there had their phone on loud audio.
Oh, man.
And you can imagine what was
Yeah,
the
the
predominant
chaos of that,
generation
uh-huh.
if they're all their
Yes.
phones. So I was
Very
like,
loud.
yes, very
Yes,
loud and
right.
all talking loud.
Yes.
So I was like, all the games were loud.
Uh-huh.
Anyway, yeah. So every waiting room has its own thing, I guess.
Uh-huh.
All right. Would you encourage your children to pursue a career in medicine?
You have to know my children.
If they wanted to.
Yes. And when my husband is more in finance, and so we have very different lives, he is always telling them that when mommy comes home, she feels like she has really helped people and had an impact, and that if she wasn't there, someone would have had a much worse day. He says he can never say that.
Oh.
And so I think he's made me see that side of things, you know, that when I walk away, I can genuinely say that I made people have a better day than if I wasn't there. And so I give that a lot of weight in my life. And so if they can have that, I would want that for them. That being said, there's many different little small choices that
Can make things better or worse.
Yep.
What a perfect guide you would be. Maybe don't go so heavy on that. That's,
yeah, exactly. And I would love one of them to be a dermatologist.
Wouldn't that be wonderful?
Are you gonna get one of them on here?
Oh, yeah, let's do it.
We do
can do it.
We do need a
We do.
dermatologist in here.
Yeah.
I love my dermatologist.
Do you have a joke about your area of medicine?
Yeah.
Oh, we gotta hear
Can
it.
you
We
tell?
gotta
Is
hear
it? I'm
Can you
sure
tell
it's
us?
clean. It's
It's
you.
just silly. It's silly, but it's my husband. I've said my husband a lot, and I really usually don't talk about him that much. Anyway, he, like, when someone's like, "Oh, what do you do for work?" and I say, "Oh, I'm an anesthesiologist," he'll come right up and he'll be like, "She puts me to sleep every night."
Okay, that's kind of
And
adorable.
I'm like, okay.
After like
heard
the
this,
50 time, you're
yeah.
like,
Yeah,
it's
here he
cute.
comes.
It's
Here he
his
comes.
favorite joke. Yeah.
That's funny.
Yeah.
Okay, our favorite question. Well, my favorite question may not be theirs. If you could do any job in the world outside of medicine, and you would still support yourself, you wouldn't have to go back and do training and all those kind of things. Oh, I feel like you have it. What would it be?
I would be somebody that you could bring your ancestral lines and information to, and I would track down your genealogy.
Oh, cool.
Wow.
That's a fun
Okay.
Yeah.
What is that? A genealogist? I don't know.
I
Is that a
guess.
word?
I don't know.
Okay.
That's what
Maybe I
I'm going
just
to do
made it
when
up.
I retire is like just
great.
go
So
back and just find it and like travel to those places and like get
Look
in
in
the
the
dusty
records.
books.
oh,
and
fun.
yeah, I
Oh.
just like love that stuff.
Have you done
Okay.
it? Have you done
I've
some
done
for-
little bits,
Okay.
but like, you know, when you're in training,
Right.
and like
It's
you're
not like you have a lot of
younger, you're
time.
like everything you do for fun like that, you feel guilty that you should be like reading about organic chemistry. But
No thanks.
I've done little bits of
Yeah.
different things.
Where have you traced
and,
your family to? Like, what's your... how far back can you go?
So my mother was a McNamara.
Okay.
And so she is Irish. And then on my dad's side, we have a lot of German. And then on my mom's dad's side, Norway.
Okay.
And then the other
Wow.
side, Transylvania.
Oh,
You're a
in
vampire.
Romania. I've been there.
Blood drawing.
There we go.
See
Oh,
how
no
far
wonder.
back it goes?
Oh, yeah. We were destined.
It's funny. That is so
Great
funny.
answer. Great
Yeah.
answer.
Well, is there any like last thought that you would want people to know about anesthesiologists, about your role, about, you know, healthcare in general? Just, you know, any kind of wise words or anything you'd like to share?
I think the stories that you're going to read online, because everybody's going to read stories online these days, are either going to be the absolute worst, most terrifying stories, or they're going to be the absolute best stories. And there's so much in between. And that doesn't get given a voice. And we take care of so many different people. And the people that are trying to take care of you are genuinely good. And at the end of the day, they are not there because they want to hurt you or mislead you or trick you in any way. We all are doing the best that we can, and we truly want you to walk away with just the best experience possible.
So great.
Yeah,
Thank
Thanks,
you so
Laura.
much for being here.
absolutely.
Yeah, we appreciate you being here. We appreciate all of you listening. And we want to remind you can follow us on Instagram, and we will be back soon in the next episode.
Bye.
Bye
everyone.
everybody.
This podcast is intended for informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views and opinions expressed by the host and guests are their own and do not constitute medical guidance for any individual case. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or health concerns. Never disregard professional medical advice or delay seeking it because of something you have heard on this podcast. By listening to this podcast, you acknowledge that the hosts, guests, and producers are not responsible for any decisions or actions you take based on the information discussed.